behalf of the Stampede investigators the fiery results of the Stampede trial. These are my disclosures. I don't think any of these have any conflict with the presentation today. I will note that the study was largely funded by Ethicon. The study has been published previously in different versions. In 2012, the first-year results were published. In 2014, the 3-year results, and then this year, the 5-year results were published. This is a 3-arm randomized controlled trial. Patients were randomized to either intensive medical therapy, which is shown here. This consisted of patients receiving American Diabetes Association guideline treatment for type 2 diabetes. In addition, lifestyle intervention in terms of coaching and drug therapy with the goal to reach an A1C of 6% or less using a variety of both oral and injectable agents. They had fairly frequent follow-up with diabetes specialists, including endocrinologists, as shown here. Patients were also randomized to either gastric bypass, as shown here, and then the third arm was sleeve gastrectomy. A total of 150 patients were recruited in the study, and 50 patients were in each group. This shows you the initial baseline characteristics of the study for those patients that were present at or available at the 5-year follow-up. And this shows you that these folks in general had fairly advanced diabetes, with the average duration of diabetes around 8 years at baseline. They were in fairly poor control with an A1C around 9% in the 3 treatment groups. And this is despite the fact that most of the patients were on 3 drugs or more, as shown. The mean body mass index was 36, and the range of BMI was from 27 up to 43, and around or nearly half of the patients were on insulin at baseline. This table summarizes the key endpoints that actually showed superiority of surgery over medical therapy. The primary endpoint was a success rate at reaching an A1C of 6% or less with or without medications. So you see here that the medical treatment group only reached that target 5% success rate, but this was much higher in both surgical groups at the 5-year mark, and these differences were statistically significant. A secondary endpoint was reaching that target without medications, which would be a definition of remission, and this was achieved in none of the medical patients, and most of the patients in the gastric bypass and sleeve gastrectomy who did reach that target did so without requiring medications. Reaching A1C of 7%, which is an ADA target of therapy, was much more common in the surgical groups. Other advantages of surgery were changes in fasting plasma glucose from baseline, relapse of glycemic control, and we define this as initially reaching that A1C target, but within the 5 years coming out of that tight control. And that shown there, change in HDL cholesterol and triglycerides also favored surgery. What is not shown here is LDL cholesterol and blood pressure. We did not see a statistically significant difference among all the 3 treatment groups. However, we did see a reduction in lipid-lowering agents and also a reduction in antihypertensive agents in the surgical groups that was statistically significant. I'm going to show you a few of the graphs that show the time changes over the 5-year period. This is the change in hemoglobin A1C. Note that in the medical treatment only group, which is in yellow, you do see in the first few months and year a significant improvement compared to baseline in A1C, but over the course of the 5 years, that benefit is reduced such that at the 5-year mark, it approaches the baseline levels. Whereas with the 2 surgical groups, you see a very significant reduction that is largely sustained, but with a trend toward rising A1C at the 5-year mark. You see a significant delta in terms of the treatment gap between medicine and surgical treatment. And then when you compare with baseline, in the medical group, only a small percent were improved compared to baseline. Most were unchanged, but a significant percent, 16%, were actually worse off than they were 5 years before, despite a more intensive medical treatment strategy. With surgery, on the other hand, you see that the majority are better than they were 5 years before. A significant number were unchanged, but a very tiny percentage were actually worse off than 5 years before. This is another way to look at the hemoglobin A1C based on the initial A1C values. You can see that the 3 groups started around an A1C of 9. The surgical groups, they dropped down approaching a mean of 6 on average, and it was fairly well sustained. In the medical group, they dropped from the upper 8 to about 7, but then slowly rose back upward to above 8 during the 5-year period. This shows you the change in body mass index. We did see a significant drop, although small drop, in the medical group, about 2 BMI points, which amounts to about 5% body weight loss, and we were happy to see that this was sustained throughout the 5 years, but much less impact than surgery. Both surgical groups here, significant weight loss, and here, as opposed to A1C, we did see a statistically significant difference favoring the gastric bypass over sleeve gastrectomy at the 6-year mark in terms of change in body mass index. This separates the higher versus lower BMI patients to see if there is perhaps a similar effect on the lower BMI. And you can see in the surgical groups, the patients with BMI less than 35, which is in blue, and greater than 35, which is in green, the changes in A1C are practically superimposable. So this data suggests that this lower BMI group has similar benefits as the higher BMI, and certainly there remains that significant gap with the medical counterparts. This shows you the change in medication, which I think is another important marker of glycemic control. This is the medication requirement at 5 years, and you can see in the medical group they're still highly dependent upon medications, especially insulin. But the folks who had gastric bypass, 45% were completely off all diabetic medications, and a relatively small percentage required insulin. And this is also true for the sleeve gastrectomy group, but was not as effective as weaning off medication. So while the previous graph showed that the glycemic changes in terms of A1C were similar for bypass and sleeve, the patients who had gastric bypass were on much fewer medications. We saw very similar trends, and just to save time, I'll just summarize very similar trends with cardiovascular medications, especially antihypertensive agents and lipid-lowering agents, a significant reduction in the surgical group compared to the medical group. Just briefly, quality of life, which was measured using a industry standard Rand Corporation quality of life instrument, measured at baseline and at 5 years. And these are separated into 2 major domains of physical and mental health. And at the 5-year mark, you see statistical changes favoring the gastric bypass or sleeve gastrectomy, principally on the physical portion, specifically role limitations, bodily pain, and probably the best overall general indicator of quality of life is general health. And there you see a significant difference and improvement favoring both procedures compared to medical treatment. To summarize the quality of life, in general, improved after surgery. With medical treatment, no change, or actually in some categories, worse than baseline. We're very interested in looking at the important clinical outcomes, specifically rates of retinopathy and nephropathy. And just to quickly conclude this slide, we did not see any significant changes. Perhaps this is in part related to relatively small sample size. relatively short follow-up, certainly much shorter follow-up than the two previous speakers that are 12 and 20 years. This is just a 5-year follow-up, so probably not enough time to really show a difference there. And I just added this to point out that in Lena's study, they clearly showed a benefit of surgery in terms of reducing retinopathy and nephropathy. So our study really was not designed to show differences there. Adverse events, no surprises there. There were only 2 cardiovascular events in the 5 years, myocardial infarction in a medical group, and 1 stroke in the sleeve gastrectomy group. No changes, as I mentioned earlier, with respect to nephropathy and retinopathy. The typical surgical complications were seen, bowel obstruction, stricture. There was 1 gastric fistula that required surgical intervention. There were some ulcers in all 3 groups. Hypoglycemia was very common. Mild hypoglycemia occurred in 90% of patients in all 3 groups. In terms of severe hypoglycemia, which was defined as either hospitalization or requiring third-party intervention, there were only 2, and they occurred in the gastric bypass group. Anemia was pretty common in all 3 groups. The most common side effect in the medical therapy group was weight gain. There were 19% of patients in that group that had at least 5% body weight gain, and the overall reoperation rate was 8%. And so to summarize the data here, the study showed that in patients with BMI between 27 and 43 with diabetes, metabolic surgery achieved glycemic control in more patients than intensive medical therapy alone. There was a sustained reduction in the need for cardiovascular and glucose medications in the surgical group. Other important cardiovascular risk factors, as shown, were reduced in the surgical group compared to medical therapy group, and the patients who had surgery demonstrated better quality of life. As stated earlier, the study has gotten some attention by organizations outside the obesity and bariatric world. The American Heart Association considered these findings very important in 2014, as well as the American College of Cardiology considered this trial one of the top trials. And I think it's just simply important for our field that we're getting recognition outside of the bariatric world. There have been now 11 randomized controlled trials that seem to corroborate this data, these findings quite well. And this forest plot shows you these 11 studies demonstrating the mean difference between A1C, the medical and surgical group. And nearly all these studies favor the surgical intervention, except 1 study, which is the 3rd from the top by Ding and others. And this was a study of gastric banding versus intensive medical therapy, which was not statistically significant. But all the others were quite consistent in showing a benefit towards surgery. These findings have led to changes in diabetes care with the new guidelines, international guidelines published in Diabetes Care last year. And these guidelines have demonstrated a stronger recommendation for bariatric metabolic surgery for treating type 2 diabetes, especially in the BMI of 35 or greater. For the first time, we have a international recommendation to consider surgery in this lower BMI group of 30 to 35, and even in certain high-risk group, like patients from Asia, lowering that BMI threshold even lower. The American Diabetes Association essentially adopted these guidelines in their 2017 annual standards of care document as well. So in conclusion, evidence from the Stampede trial and 10 other randomized controlled trials demonstrates the relative safety and efficacy of surgery as a treatment for type 2 diabetes. And now we have international guidelines that have been widely endorsed by more than 50 medical and diabetes organizations throughout the world. And I'd like to acknowledge my co-investigators of the Stampede trial, especially Dr. Sangeeta Kashyap, who is our lead endocrinologist. Dr. Deepak Abhat is a Harvard cardiologist. John Kerwin is a noted metabolic researcher. Kathy Wolski is a world-class statistician. Leah Minion and Stacy Bretthauer are bariatric surgeons. Dr. Bretthauer is the current president of ASMBS. Some other key investigators, and also Dr. Stephen Nissen, who is a chair of cardiology at the Cleveland Clinic. Thank you very much for your attention.